Okay. Hello. Okay. Module 4, resonance disorders. So usually resonance, we're referring to what I, like to call just nasality. So how is this sound, their voice, how is it coming out of, their structures? What does it sound like? Is it coming out oral through their mouth or through their nose, or do we hear kind of what we call nasal air emission, or does it sound like they're all stuffed up? So usually that's why you can usually hear somebody is sick or have some kind of different, and then it kind of triggers me. I start coughing or trying to clear my throat. Definitely, it's kind of how the noise reverberates in our vocal tract is basically, and when you hear resonance, please usually think about nasality. Is it hyponasal, hypernasal, or sometimes, for instance, I just did an evaluation for a client and lots of nasal air emission. So he was articulating correctly, but speech was a little off because of the nasality piece. And so a couple different things. Let's look at resonance disorders. I don't like how it comes up on here. Hold on. 1 minute. Here we go. So pretty often we usually see some issues with resonance with cleft lip and cleft palate. So definitely some of the most common birth defects that occur in North America. And definitely what I want to say, it affects different here. Cleft lip, cleft palate occur across, it's global. So, but we definitely see it often in Asian, Latino, or Native American. And there is some good research that explains why, but definitely it's a birth defect that kind of comes up, but it's also, what I want to say, the most treatable, the most repairable, definitely something that, and can vary in severity. So sometimes someone with a cleft lip is not a huge ordeal. It usually just requires some stitches with plastic surgeon and how specialized therapy surgery is. Oftentimes we don't even notice, you can't even see. Definitely some excellent gains as far as surgical interventions for these people who are born with this malformation, and it definitely can be varying degrees. There is sometimes a severity level. And oftentimes, if there's a craniofacial issue, they oftentimes work with what we call the craniofacial team. So there's definitely a group that works with our people with cleft palate and cleft lip or any kind of craniofacial. It's usually, there's a plastic surgeon, oftentimes otolaryngologist, gosh, I can't say that one. Definitely a dentist, definitely lots of dental work usually in their future. The auditory and hearing specialist, of course, because oftentimes we see there's kind of a connection with that anomaly, birth defect. So often we see some hearing and even some vision things too. Genetic counseling as well as possibly a social worker to help people get access to these services. So definitely it's a team of people that work with this client as well as the family. So velopharyngeal insufficiency. So let me use this word. Velopharyngeal insufficiency due to malformation or malfunctioning. So basically, here is the challenge that I have, and based in my experience in Arizona, not necessarily in other states, is oftentimes, and I agree with this approach, But definitely if there's, oftentimes we say, oh, they have a speech issue, go to speech therapy. But especially when we're looking at resonance issues, oftentimes they really need to see an ear, nose, and throat specialist. We maybe need some more surgical kind of checks before we know speech therapy is effective. So depending on what kind of testing they've had, where the referral came from, I really wish sometimes we can get confirmation on a malformation versus a malfunction. So malfunction just means something's not quite working right, but they have all the correct structures and parts there. So in all reality, it should be working right. So definitely speech therapy oftentimes is very effective. Malformation, there's no amount of therapy that's going to change the formation of your mouth, the palate, the structures in the ear, nose, and throat. So that's kind of where like the structure, you know, we can work out as much as you want. It's not going to make you taller. So definitely it's kind of that philosophy. I wish sometimes we always had better information before we start. So there are some surgical options. So, excuse me, velopharyngeal insufficiency basically means the velopharyngeal port isn't closing against the pharynx. So oftentimes we have what we call hypernasal speech. So velopharyngeal insufficiency indicates there's nasal air emission. We're not having, the velopharyngeal port is not closing. So sometimes it closes against something and then we take it out. So sometimes it just needs to learn how to close back further, especially when tonsils and adenoids come out. So there's some things to look at with the insufficiency component. There is some surgical options to help with that. So there's the pharyngogeoplasty, sphincter pharyngogeoplasty, and pharyngeal flap. And oftentimes we do therapy before and we do therapy after. And oftentimes if they have something like this, they're going to need subsequent surgeries as they get older and they grow. So it depends. How many surgeries is average to correct? So it varies from patient to patient. Sometimes just one, that's it. Sometimes there's several. So what happens is depending on the degree of the cleft, depending on the degree of and where sometimes it is, as well as if there's palate involved. So definitely, and then when we look at dental stuff, so sometimes it's more. Oftentimes oh gosh, I feel like that changed again. I thought it was at least 2, I think 3, but the other part is the sophistication of the surgery now. Sometimes there's things that they can do to improve the look, especially now when I look at the adult clientele that maybe didn't have as many state-of-the-art surgical techniques as they do now. So definitely we've seen some kind of revision of those in some adults, but oftentimes speech therapy kind of helps work on that insufficiency or mislearning. Now, and sometimes, so sometimes we just need to try it and see if it works. And usually if it's just mislearning, so this summer I did an evaluation, myself and another therapist. I really didn't want to recommend therapy because I definitely felt like there was something structural based on what we could tell. But I remember telling the mom, the only person who really can tell us is an ear, nose, and throat specialist. So here are my concerns. Here is what, it was great because she actually had an appointment pretty like within 2 days of us doing the speech therapy eval. So it was great that we got some instant feedback, and definitely, the ear, nose, and throat specialist ruled out any kind of malformation or structure issue. So then I felt like it was ethical to recommend speech therapy because I think we can, help her. This poor little girl is really unintelligible, really smart, but lots of nasal air emission. And we weren't sure. And this was also like a foster to adopt. So we didn't know her whole history, nor did the parent at this point. So definitely we were trying some things, and I was explaining kind of these differences on speech therapy might be appropriate, but we really need to kind of have a doctor look and say yes or no. Like I said, we cannot change structure no matter how much therapy we do. So the right time for therapy is usually when nasal emission is mild. And like, for instance, this client had pretty significant nasal. I mean, I couldn't even get any oral airflow at all. If the student has developed other articulation errors as a compensation for nasality, and sometimes when the nasality is phoneme specific. So every now and then, all of a sudden they learned sometimes to stop consonant. Like I had a client did a nasalized P. I don't think I can even, I don't know, it seemed hard. I couldn't even do it if I tried. And it just was sometimes like a mislearning. So instead of like M being nasal, it was the P was nasal. It was very weird. And sometimes though, we have hypernasality is due to apraxia or dysarthria. So when we're looking at our clients who have aphasia, have had some traumatic brain injury, and now we have dysarthria. So apraxia and dysarthria usually indicates neurological difficulties. So auditory feedback, obviously we need to help them hear the difference in the nasalities. And then there's some ways to do that. And definitely, so here we go with the oromotor exercises. Okay, let me be specific. You might do an activity that looks like an oromotor exercise to help them understand oral airflow versus nasal, but we're not necessarily doing that to improve articulation. We're more about where is the airflow coming from? That's the purpose of some of those exercises. So just know that you might do a couple of those activities to help them with the nasality. So for instance, I have a student that I highly suspect has neurological challenges, and it's why his speech is very hypernasal. There's some things there, and definitely he struggles with the airflow and where it's coming from. And now in doing these activities, I realize he does know the difference, which why it also strikes me as maybe it is more neurological, because he understands the difference. I don't think this is a mislearning. This is, he really can't physically control it. So there are some cool therapy things to do, and they have cool tools to use to help with this. Definitely some great stuff if you ever get the opportunity to work in a voice lab or with an ear, nose, and throat specialist. They have some great instrumentation the average clinician doesn't have. Definitely at the universities, they have some cool stuff that really helps this. One of my, she's a professor at University of Illinois now. She's a person I went to grad school with. She understands all this stuff. And some of the instrumentation I see when she posts things on social media, I'll send her a funny message. Hey, I got a student for you. Where do you recommend here in Arizona for me to go to kind of get this information? So definitely some cool instrumentation. The average clinician doesn't have this, but oftentimes specialized voice clinics do, which is really nice. So tactile kinesthetic feedback. So what does that mean? So we're giving them feedback. Obviously, what we want them to do is feel the difference between the airflow. Can they feel it when it goes out of their nose? Can they hear it? Oftentimes too, we do, there's a cool activity to do with like a mirror so they could see, hey, there's airflow coming out of your nose, especially when the mirror fogs up. That's kind of gives them that visual feedback. And then the tactile, like, can you feel the air? Oftentimes too, I work on, do you feel the air coming out of your mouth, or do you, and oftentimes too, you could feel the air coming out of the nose. So sometimes we work with some of that tactile kinesthetic feedback on how to help them feel the differences, or sometimes you can have them do things where you can get that velum up. We really want to get it to get contact. So, you know, we might give them some feeling in their mouth, although I'm not really a fan of sticking a tongue depressor in a child's mouth. That's not necessarily my style, but we've used it at times to give them that tactile feedback or where in their mouth. Definitely like the yawn technique kind of helps. Some great little activities that kind of gives that tactile kinesthetic feedback that they might need to help with that resonance and controlling that velopharyngeal support. So some other things too, you know, pinch their nose. Can you hear the difference? Definitely feeling that vibration, that tactile feedback is helpful. So do not use blowing or sucking exercises. Those will not impact speech. Do not do velar exercises. So the exercises. So I'm not going to have somebody just blow a cotton ball across the table to, you know, strengthen their oral airflow. Sometimes, like I said, the purpose of that is not to strengthen anything. It's to help them understand airflow. So if you do something like this with regards to nasality, but practicing blowing across the table isn't going to improve necessarily their nasality. Sometimes you have to do it to have them understand, and depending on the child's cognition, other factors, sometimes they need that feedback to understand when we're talking about blowing out their mouth versus nose. Sometimes I like to just do it to see if they can close it off, or is it really hard to do a blowing task, and then I can see how much air is emitted usually. But to do them over and over again to strengthen anything, no. Or velar exercises don't really help. Sometimes you need to do something to help them understand the area of the mouth. But oral motor exercises to strengthen for this particular thing the evidence isn't there to support using that. Like I said, I have done some blowing stuff to help them understand airflow things. And there is a nasal horn that sometimes kids start to understand, oh, I'm getting air out here. So definitely sometimes you need to differentiate those, but to do them over and over again, once they understand the difference, you don't need to keep doing them. So we discontinue therapy if progress is limited. And obviously this is where we're making other referrals. I also want to say that really, truly, I would hope before they get to your supervisor for an eval that someone has seen an actual doctor, and the pediatrician made a referral to see an ear, nose, and throat specialist. Sometimes they don't. Sometimes the first they hear of it is from us. So there's a resident treatment observation. There's a quiz, and the quiz is just, there's no note card on this. It's real basic. So really review your vocabulary. And please, the difference between hyponasal and hypernasal, be sure you're real clear on that. That will help you in other ways. If you know the difference between hypo and hyper, that will be helpful. And then we have, hold on. A read and review summary. So here's just some other, this is a review of the anatomy. And maybe I should list this one first and the other one. But a lot of you are familiar with this. Hopefully 210 is fresh in your mind. Do you know the structures and parts? So resonance is the balance of sound vibration in the oral nasal pharyngeal spaces. So resonated with our nasal sounds are N, M, and I and G. So it's a little bit of a 214 review. And really, you have to have a good pharyngeal port for normal resonance. So changes can be made by obstruction, malfunction, and malformation. So sometimes the biggest obstruction we have back there is tonsils or adenoids. And definitely we see some challenges sometimes pre-op and post-op with a tonsil and adenoid and adenoidectomy. Did I say that right? I think. So you can kind of look at some of where we want the closure. It's open for those nasal sounds. It's closed for all other consonants. So incompetence, physiological weakness, paralysis of the velum that does not allow for proper contact. So we're looking at the structural defect versus mislearning, and a common one, and I think it's common, I say common, if we don't have a cleft palate or cleft lip, that velocardiofacial syndrome definitely has some impact with resonance. And usually that's a syndrome where there's a variety, you have some different signs, and then they should test somebody for this. I think this one's actually underdiagnosed. So most common causes of velopharyngeal, what did I put with dysfunction, disorder, velopharyngeal, or deficiency, excuse me, there we go. Sorry, I hate when I sometimes use an acronym and I don't remember what it's for. Okay, cleft palate. Okay, apraxia of speech also. We'll see some issues with resonance. A submucosive cleft. So that's definitely, you'll see where there's no hard palate, and those are of varying degrees. So they'll have tissue there, but no hard palate, no bony palate. And large adenoids, I think, is probably the number one we see around here. And other neurological disorders. So oftentimes we see some of those neuro-based things. So a common one that I see is with some resonance issues is our clients with cerebral palsy, our clients who've had some kind of stroke, some kind of head injury, oftentimes where we have some neurological impairment, we see some challenges there, or permanent damage, I should say. So here's kind of that, you'll see that left unilateral cleft lip and palate. So sometimes there's just a lip, there's just the lip involved. Sometimes it's just the palate. Sometimes it's the lip and palate. Sometimes it's one side, sometimes it's two sides. And obviously a bilateral cleft lip and palate is more intense than just say a cleft lip. So those are some differences there. Kind of see, so submucosal clefts and bifid uvula. So when I look at here, you usually see kind of what I call a little hole. Here's like a normal palate, so you'll see that line. What's funny is, so I have a bifid uvula, and I didn't even know until I was in undergrad, and we were working on anatomy physiology, and she's showing how to do an oral mech exam. The instructor was like, "Oh my goodness, did you know?" And I thought everybody just had like two. So mine looks like that on my but I don't have a, it's so funny because she's like, "Well, let's check you for this." I don't have anything, but that's an indicator. You see that in a mouth, you need to tell your supervisor, because every now and then, sometimes your supervisor does an eval and the client won't let them look in their mouth. And then once they start doing therapy, they get a little more comfortable, and then you get to look in their mouth, and then we see things. So definitely, if it's not noted anywhere, your supervisor hasn't talked about it, be sure if you see that and you didn't know they had one, please let your supervisor know. Oftentimes it indicates a submucosal cleft or some other kind of palate abnormality. So enlarged adenoids. So depending on where the adenoids lie, depending on the age too, and how much swelling, it definitely impacts that closure. So the tonsilline adenoids can be super impacting their overall actual intelligibility as a whole. But definitely we see some big differences. And I have to say, I think sometimes that those adenoids impact middle ear stuff. It also, I think, impacts the way they hear things. So if you ever had like a clogged and it kind of, sounds different. You're like, gosh, I sound like I'm in a vacuum kind of situation. Sometimes I think it distorts their auditory system. So definitely, I think large adenoids is probably the number one health issue that's, not treated accordingly. And I get it because surgery is pretty invasive, and just because you have enlarged adenoids, surgery might not be indicated. But I do think in some of our clients we work with could definitely benefit from having their adenoids removed. So then tonsils, the next thing is tonsils. It's kind of like adenoids and then tonsils. So sometimes when they have enlarged both, you definitely get a double whammy. The other problem that I have with those tonsil and adenoids, I do think it impacts a client's sleep. So we definitely see more sleep issues. I feel like we see some more behavioral things that could possibly be related to sleep. Definitely we see some things that I think are underdiagnosed and undertreated, and definitely with this enlarged tonsils and adenoids, I always worry about the quality of sleep and rest a client is getting. So those are some of my pet peeves with that. And look at his air. So if you think of the average amount of air, I can't imagine his oxygen levels are great. He's probably not getting good oxygen levels on a regular basis. And this comes more when I worked in the rehab hospital. We definitely talked about, like, your pulse ox, your resting pulse ox, when especially a child has tonsils and adenoids that enlarge, I guarantee that we're looking at sometimes some oxygen deprivation at various times of the night. Definitely can impact snoring, child snoring really loud. That's not typical. Usually indicates some tonsil and adenoids issue if a child's snoring, and I mean snoring loudly, snoring more like an adult kind of situation. Definitely, I think it impacts their quality of sleep, and that's not good for anybody growing. So that hypernasality can impact articulation as well as intelligibility. Hyponasality is where, everyone sounds like they have a cold. Cul-de-sac resonance, it's muffled resonant quality, often due to enlarged tonsils. And what I also want to say about cul-de-sac resonance, sometimes our clients with a hearing impairment, pretty significant, can have that cul-de-sac resonance also. And I think that definitely comes from some challenges with their own auditory feedback system. Now, abnormal dentition and occlusion, it's another thing too. Sometimes our structure, the way our dentition is, and occlusion. So definitely some of those jaw misalignments, teeth that are a mess, can absolutely impact all of those resonance factors, as well as our bite. I think sometimes we get dysfunctional. In fact, today I got some permanent retainers. I've been doing Invisalign and I can hear it in my voice. So I definitely, give me a couple weeks. But those can all impact, especially when we look at our clientele that's growing and changing, and maybe at different points in their development where some of these things might be impacting them. I think it's always a component we have to take into consideration. And some of this is outside our scope. So sometimes this requires work with an orthodontist, ear, nose, and throat specialist, their pediatrician, and of course, who has access to the healthcare, and what are those healthcare providers recommending. So let's say, for instance, I had a client, lots of facial stuff, but he was very, what I would call medically fragile, had a lot of medical indicators, and they didn't want to do any kind of unnecessary surgery. So we had lots of talks and discussions about, the risks definitely outweighed the benefits as far as doing that procedure. So the benefits they felt were mild and, not worth the risk. So there's definitely some of those things depending on the client and the other comorbid issues that are occurring. So resonance errors, obviously, definitely sometimes phoneme specific nasal emission, like if you only hear it on a phoneme, it's oftentimes just kind of a mislearning of it. Any kind of submissions or omissions or distortions. So sometimes the sound distortions, it's not so much a misarticulation. And then the other thing I want to say too is when we've got resonance issues, we definitely sometimes see a decrease in their MLU. So their mean length of utterance oftentimes is shorter. So maybe their expressive language can start to look impacted. Definitely a lot of times we see decreased ability to sustain airflow. So definitely they need more breaths. Sometimes they get dysfunctional with how they take breaths in the middle of talking. Definitely that impacts your overall intelligibility, as well as just your language in general. Other things too, we definitely can see some self-esteem issues, other negative reactions. And I think sometimes when we hear something like off, it doesn't sound right, but they don't necessarily misarticulate it. So sometimes there's not just like a sound substitution. I think sometimes those are easier to understand, especially in our young population versus other errors like resonance. Definitely can impact self-esteem. And so there's some hypo. So if you don't know what hyper or hypo, that link, I'll try and see if that link should work. So there's just some, those are just some things to remember for this week. Know the difference. So hyper is too much air. Lots of nasal airflow. They're hypernasal, lots of air coming out their nose. Hyponasal, you got a cold. You don't have any air coming out of their nose. And then of course there's varying degrees. Sometimes I think the challenge arises with some of those submucosal clefts, some of those other kind of structural. Sometimes the nasality is at the palate level, not necessarily at the velopharyngeal port level, and that's a challenge. You know, if they don't have a hard bony palate, they don't have a hard bony palate. So sometimes we have to teach some compensatory strategies to help them be more intelligible. But that's really the main thing this week is understanding hyper versus hypo. When we're talking about nasality, we're talking about a resonance. Like I said, cul-de-sac resonance is another thing that we hear. We talk about that sometimes with our clients with a hearing impairment. And maybe when we're trying to work on articulation and improving their intelligibility, their speaking intelligibility, definitely we can see some resonance. So hearing loss, and then kind of that broad-based neurological disorders, we see a lot of nasality resonance come into place, especially for dysarthria and apraxia. And sometimes it takes a little bit of therapy to tease out some of those differences too. So any other questions about that? So there's an observation, a quiz, and then a read and review seminar, a read and review summary. And that's really it. Any other questions before we sign off? I appreciate you joining me. All righty. Thank you, guys.